Awesome. With that in mind, we'll go ahead and begin. I know that we have a few people joining in, but we want to say good morning and welcome you to our first NCSD DIS mini conference. We're looking forward to a great day of learning. And before we dive any further into the conference, I want to have our executive director, David Harvey, issue us an official welcome, and then we will move forward into the day. Thank you. David, I'll turn it over to you.
Thank you, Leo, and welcome everybody to NCSD's first DIS mini conference. I am thrilled to welcome you to today's day-long Zoom meeting where we have, I believe, the single largest number of participants ever in a Zoom conference that we have been conducting. We have 1,150 registrants. And so thank you all for joining us today. Bear with us a little bit in patience.
Well, maybe because they have so many of us, they're not going to do break rooms.
You're muted.
Leo and NCS team, can you all hear me now? Okay, I'm going to start over because I think we had a little bit of a glitch with the mute function. Everybody, welcome to the first ever NCSD DIS mini conference. There is 1,150 of you registered for this meeting. That is a record. I'm thrilled to welcome you. NCSD has been working very hard to support DIS nationally throughout the country. During the past few years, we've worked hard at welcoming DIS as a core membership component of our organization, and we have expanded training opportunities enormously over the last couple of years. Some of you may know that we are a DIS training center as well, working in partnership with the STD division at CDC on core training materials for DIS. And shortly you will hear from DSTDP's largest DIS, the champion that we have at CDC, and that is Francis Rutgeiser-Bannister. Francis, thank you so much for joining us at today's meeting. I don't have to tell all of you that you are on the front line of outbreak response in our field. NCSD was thrilled to play a central role in securing special one-time additional funding to support the expansion of the DIS workforce in America, $1.2 billion, the single biggest infusion of resources into our field in our history. This funding is making it possible to expand DIS throughout the United States and to provide the training and the resources you need to respond to your local needs. DIS are on the front lines. We're on and continue to be on the front lines of COVID. You have been involved in combating Mpox and, of course, the ongoing record high numbers of STIs that we have in the United States. Thank you for everything that you do every day to support our field and your local communities. If you have not registered to be part of my NCSD, you will want to do so. There will be additional information conveyed in the chat and later on in the meeting about how to get involved with my NCSD, which is the online platform. It's a main communication and training vehicle that we are using to reach many of you across the country. You should also know that NCSD will be launching a LMS system, a learning management system, which will expand our capacity to be able to offer online learning and training curriculum opportunities. So stay tuned for more information about that. At the end of the day, this work that we do at the national level is all about elevating your voice. your work that you do on the front line. No one knows better what's going on in America in local communities across the country, whether it's STI prevention, Mpox response, or COVID, than all of you. So we're here to learn from you, help you exchange expert information among each other, and to elevate your voice at the national level so that policymakers and others are hearing about the needs of our field and your work. So thanks for joining us today. I want to thank Leo Parker and Sonia Khan for being our lead organizers of this mini conference today. There is virtually an involvement by the entire NCSD staff also today in putting on this conference. Many thanks to the NCSD team for supporting this meeting. This is the first of many additional meetings to come. If you do not know about STD Engage taking place in May in New Orleans, please go online to our website and find more information about the conference. There will be lots of training and networking opportunities for you at the meeting. So it is the goal of this mini conference to be the lead-in to STD Engage in May. So once again, thank you for joining us today. Welcome. And Leo, I'll turn the podium back to you.
Thanks so much, David. If we can move to the next slide, that would be great. As David mentioned, myself, along with Sonia Khan, has been working to make this mini DIS conference take place, as well as Talia Parker, who is no longer along with us. She did a lot of great legwork prior to her leave. However, as David mentioned, it does take the work of the entire NCSD team to make a conference of this nature come off. Just wanted to take a second to introduce our conference team to you all. I won't go through each one name by name, but we'll just go through the next couple of slides just to introduce them, as well as paying knowledge to those that are not on the screen who have been working behind the scene. Thanks. As David mentioned, this is probably one of the largest webinars or meetings that we have had. And as we mentioned, it is in a meeting format, which means that we have the capability of being a little more interactive than we normally would in a webinar. So we just wanted to take a couple of seconds to go through some housekeeping for today, so that we can make sure that this webinar meeting is enjoyable for everyone. For those who may have any accessibility needs, please direct yourself to Marlena Kincaid. Marlena is in the list of people. Just feel free to click on her name, send her a direct message. She will be happy to help you. If at any time you begin to experience any technical needs, please direct your message to Michaela Shako. Michaela will be happy to assist you with any tech support. We do have accessible processing guide on the event page, and I think also in the chat for those who may need help with any accessibility. Because this is a meeting, please be mindful of staying on mute. That will give us the opportunity to continue to enjoy this conference as much as possible. Any slides, resources, and the recording for today's conference will be made available after the conference. If you have any questions or needs after the conference, please feel free to contact Sonia. Her email address is here in the slide, as well as we will make sure that you have it afterwards. Also, just wanted to make sure for those that may have questions throughout the course of the day to please drop your questions in the Q&A and not in the chat. That will give us the opportunity to make sure that we see your question and that we're able to answer your question as soon as possible. Also, if you notice, a lot of the NCSD staff has a special Zoom background for today. If you would like to join in on the fun, these backgrounds are also located in your chat. Feel free to download one to update your background. This is a meeting format, so we do have a capacity of 1,000 participants for today. So anyone who may leave the conference and come back, it is a possibility that you may not be able to get into the conference. If that is the case, we ask that you please be patient with us. We will try to admit as many people as we possibly can. And then just keep in mind that we will share the recording after today. Also, lastly, with everything, we want to know how you enjoyed the conference. So after today, you will receive an evaluation so that you can let us know how we did. For those who complete the evaluation for the first 300, we will mail out a special NCSD gift to you. So that is it for housekeeping. And so now I just want to run through this morning's agenda. Next slide.
I think we might be switching screen sharers in a second here.
All right. If you all will, please just give us a second. I think we're switching. Thanks so much. Just by way of morning agenda, we will go from 11 a.m. until 1 with a break from 12 to 12:10. With that, moving forward, we would like to move into our first presentation of the day. Next slide, please. With Disease Intervention Training Centers updates brought to us by Kaitlin, Francis Rucker Bannister, and Denise Tafoya. By way of introduction, I will introduce Ms. Francis Rucker Bannister first. Next slide, please. Francis serves as the team lead of the Workforce Enhancement and Development Unit at the Division of STD Prevention at CDC. Francis has over 20 years of experience in training, partner engagement, program management, grants, co-ags, and contract management, executive coaching, and team building. She currently serves as the team lead for the Workforce Enhancement and Development Unit in the Division of STD Prevention, where she is responsible for the portfolio of Disease Intervention Training Centers cooperative agreements and training efforts for internal and external disease intervention staff members. Kaitlin serves as the Manager of Training and Coordination at NCSD, National Knowledge-Based Curriculum Development and Training Coordinating Center. As Manager of Training Coordination, Kaitlin oversees the coordination of the National Network of Disease Intervention Training Center, NNDITC, to deliver online and instructor-led DIS training courses. Previously, Kaitlin served as NCSD's project coordinator, programs providing administrative support for the NCSD programs team. In addition to the NCSD Program Committee and DIS Advisory Committee, prior to joining NCSD, Kaitlin worked with the Commission of Collegiate Nursing Education. Denise Tafoya is the program manager for the CAPTC-UCSF National Skills-Based Curriculum Development Center and Curriculum Development Center and Disease Intervention Training Center for Region 4. Denise has over 25 years of experience in STI and HIV prevention services working as a DIS frontline supervisor, field operations manager, and DIS trainer. Also a co-author of several skill-based courses for new and experienced disease intervention staff. At this time, I'll turn it over to Kaitlin.
Thank you, Leo, and thank you to the participants here today for the opportunity to share this information with you on our National Disease Intervention Training Program. I'm going to send it over first to Francis to share more about our DIS training plans and resources. Francis.
Good morning to everyone. If you could advance to the next slide, please. So it is such a pleasure to be with you this morning and to talk to about and give updates on subjects that are near and dear to my heart. So I just want to start with giving kind of the overall piece about DIS training. So the depth and breadth of job tasks involved in the DIS role, as many of you know, requires a multifaceted training plan to support the development of core competencies and proficiency in essential tasks. There is no one training that will meet all disease intervention training needs. In order to build disease intervention capacity, it's very important that skills building and educational opportunities include both knowledge and skill-based training in essential job tasks and cross-cutting core competencies. It should also be inclusive of on-the-job training to observe and practice disease intervention interviewing and investigation skills. Awareness of applicable federal, state, tribal, local, or territorial laws and regulations regarding public health authority, communicable disease reporting, confidentiality, privacy, and data security are also important parts of that, as well as proficiency in the use of technology to access surveillance and other essential information and facilitate communication with people diagnosed with or exposed to infectious diseases. Next slide. So some of the resources that we have available for you and where you can go for some of those resources. CDC has Disease Intervention Resources website, and we'll make sure and drop the link in for you so that you can access it. But as was also stated, you will receive copies of the presentation and can access the information. This website has a variety of resources and links to training, which is inclusive of learning plans that are housed in CDC Train, and many of you can also access them through your other individual train modalities in your own jurisdiction. There's no cost, and people can take the trainings at their own pace. Two plans that we highlight on the website are the Disease Intervention Training Plan with Outbreak Response, and that's course ID number 5110. This training plan includes the fundamental disease intervention skills from the DIS fundamental training, as well as additional modules specific to outbreak response. We also highlight another training plan entitled Introduction to Public Health Practice. And this training plan includes courses in health equity, communication skills, policy development, data analytics, and more from different public health organizations. Other national level opportunities currently available to help develop disease intervention skills are our program called CDIS, which is Coaching for Enhanced Disease Intervention Skills. CDIS is a skills building program that pairs experienced disease intervention staff with newer disease intervention specialists, and it is an 8-week coaching program. I emphasize the word coaching program. It includes virtual one-on-one sessions where participants enhance their core DIS skills in such areas as interviewing, rapport building, problem solving, and cultural humility. In addition, one of the other programs that we have that's sort of being done on a national basis are our facilitated partner services interview practice sessions. This program offers disease intervention professionals an opportunity to role play during practice interviews for syphilis and HIV cases. The interview sessions are facilitated by experienced disease intervention professionals from CDC's Division of STD Prevention. We also have technology-based partner services, toolkits, and National Internet Partner Services listserv, which we'll also ask that get dropped in the chat as well so that folks can take a look at some of those. Those are a few of our DIS training resources. And I will also now turn it over to Kaitlin, I believe, who will take us into some of the other parts that we have available under our training. Kaitlin?
Thank you, Francis. Great. So another resource that I'll talk to you about today is the National Network of Disease Intervention Training Centers, or NNDITC. NNDITC is a network of training centers located across the country that included a knowledge-based training center, a skills-based training center, and 4 regional training centers. The NNDITC supports the community of disease intervention professionals through the development of e-learning and skills building training. Next slide, please. Our website, seen here, provides links to relevant resources as well as free learning collaboratives. The NNDITC learning collaboratives are interactive live sessions tailored for disease intervention professionals. I will now hand it over to Denise from the National Skill-Based Curriculum Coordination Center to provide more details on the topics covered in these learning collaboratives.
Thank you, Kaitlin. Next slide, please. Welcome, everyone. So in addition to the many online training events, we also have virtual instructor-led skills-based training opportunities that are available to enhance your capacity to conduct disease intervention work. These learning collaboratives range anywhere from 2 to 4 hours, and they involve a great deal of interactive activities and discussion. They're going to be useful for all levels of disease intervention or DI providers conducting communicable disease work. There currently are 7 learning collaborative topics that rotate weekly. Some of them include strengthening cultural humility awareness when working with MSM. And this is intended for DI providers who are interested in exploring and learning how providers' values and stigma can impact HIV care for the MSM community. We also have an approach to working with people who use drugs. That program is geared for people who work with people who use drugs. And here we're going to address the 3 principles of cultural humility, motivational interviewing, and then person-focused harm reduction. I'm not sure how long I was muted, but let's go back to the people who use drugs. Learning collaborative is geared for providers who serve people who are using drugs. And here we address the 3 principles of cultural humility, motivational interviewing, and person-focused harm reduction. Participants then will apply these concepts to different case scenarios to develop appropriate strategies and then referral options for people who use drugs. We also have a disclosure of STI and HIV status within the context of self-referral of partners. And this is going to provide skill building opportunity to assist disease intervention professionals in supporting people who are diagnosed with an STI or HIV, who want to share their health status with people in their social and sexual networks, and then inform them of exposure to infection so that way folks can seek testing and treatment services. And then for those of us who go out into the field, we have the maintaining personal safety during field notifications. Now, this program was originally designed as a proactive response to the increasing potential for incidents of violence and threats of injury to disease intervention professionals who conduct in-person partner notification services, or maybe they're doing outreach, or just any other kind of public health related activities in the field and the communities that we serve. We're going to be dropping links in chat to each of these collaboratives for easy access to registration. Next slide, please. Also, registration is open for the first 3 collaboratives of our 4-part STI HIV interviewing learning collaborative series. So first is the overview of STI HIV interviewing. This learning collaborative is going to cover STI HIV interview concepts and the STI HIV interview format. We'll also cover the introduction component of the STI HIV interview and address pre-interviewing considerations, as well as activities that are conducted outside of the STI and HIV interview setting. And then we'll also speak to how do you respond to reactions from people being interviewed. The second in the series is social and medical history taking, the why behind the what. And this collaborative is going to focus on the assessment component of the format. And it's also going to provide you with a rationale behind asking certain questions that are related to disease comprehension, social history, medical history, and then sexual and drug use history. The third in this series is called The Anatomy of Problem Solving During an STI and HIV Interview. This learning collaborative covers problem-solving techniques to implement when conducting your STI and HIV interviews, as well as problem-solving models to help the person diagnosed with an STI or HIV take action. And then coming soon is the social sexual network elicitation, a deeper dive. Now, this collaborative is going to cover the disease intervention component of that STI and HIV interview format. It will cover how social and sexual networks affect STI and HIV transmission. And it will also cover how to conduct a contact and a partner elicitation work. All of these collaboratives are super informational, they're activity rich, and they range anywhere from 4 to 6 hours in length. We do provide several breaks to keep your energy and your participation high. It's important to tell you that these programs do not replace the upcoming foundational course, Principles, Practices, and Pathways to Disease Intervention, also known as 3PDI, but they will serve as interim training to support your development as disease intervention professionals. And we're also going to drop a link in chat so that way you can access registration to these disease intervention programs as well. So let's quickly talk about the course replacing the Passport to Partner Services program. Next slide, please. Okay, so we've covered what is currently available for training, but the question that we've been hearing the most is, when will the replacement course to Passport 3PDI become available? First, I just want to recognize that without either 3PDI or the Passport program, there is a gap in skill building for STI and HIV interviewing. We acknowledge frustration around delays in the 3PDI release, but we're super confident that some of the other training and workforce development opportunities that we walked you through will help meet the state, tribal, local, and territorial needs. Currently, 3PDI is slated for our 2023 release and is going through the content approval portion of the clearance process. So what will 3PDI look like? You're getting a snapshot here on the screen here, but this program has two components, an e-learning component and a skill building component. So with e-learning, you're going to get all your infectious disease modules covered here, as well as operational responsibilities, building awareness, empathy and support. It will address introduction to partner services, interviews and case analysis, as well as data and technology, field work and distance-based communication. And of course, we can't forget introduction to outbreak response. Now, the skill building component is going to address surveillance and epi support, as well as planning and prepping for your case and your field work and investigative activities, and then opening and maintaining dialogue. Conducting interviews and case analysis will also be addressed, along with collaboration with the healthcare system and care coordination and referral for services. So I hope that you will join us as soon as this program becomes available. Thank you. I'll turn it back over to you, Kathleen.
Great, thank you guys. And if you missed any of these links or want to learn more about our learning collaboratives, please visit our website, seen here, or send an email to us at nnditc@ncsddc.org. And if you have any questions, I think we would ask that you put them in the Q&A, but thank you all.
Thank you so much, Kathleen. Thank you so much to the DITC team. As Kathleen mentioned, if you have any questions, please put them in the Q&A, and Jerica will let us know if we have any questions in the Q&A. We will take a couple of seconds just to give you the opportunity to put those questions in Q&A.
There's one question I think was already answered about if these trainings are going to be available on demand. It looks like they are not going to be available on demand, but only on certain dates. Is that correct?
Yeah, I can take this one. So the live sessions are offered weekly, and they do rotate, so they're offered pretty frequently, but we do not have an on-demand option at this time.
And we see a few people have said that they do not have the Q&A option on their screen. If you will, just drop those questions that you may have into the chat, and we will do our best to answer those in the chat. And if we are unable to get to your questions, we will take those back to the team so that they can answer those and we can get a response for you.
We have another question. Is it possible to be able to register for these trainings in a way that is not regional? I've had a barrier to registering as my region is usually the same day, same time for trainings.
Francis, let me know if you want to chime in as well. I know that we're looking into offering some options that are going to be a little more broad and outside of the region-specific kind of barriers right now. And we're hoping to kind of develop that in the next couple of months. So please be on the lookout for that.
That is exactly right, Kathleen. We are in the process of trying to ensure that we can remove as many barriers as possible. So continue to be on the lookout.
Jerica, we'll take one more question before we move to the next presentation.
Okay, perfect. It looks like the last one we have in the chat is, will these help with DIS certification?
Francis, would you like to take this one as well?
I'll answer this in a broad way. I believe that there is going to be a presentation about DIS certification and the process, and that any training that that folks are taking that is kind of in the DI world and sanctioned sanction my word, would be helpful in preparation for when DIS certification becomes available. But it is a process, and one that I hope you will listen in to the presentations that are coming and continue to avail yourself of that.
Please. Next up, we will have expanding EPT initiatives with, and I apologize if I mess up anyone's name, so I apologize, with Kaitlin Cafferky of Orange County, New York, Kayla Heeekin of Essential Access Health, Bianca Clarke of Michigan DHHS, and Kevin Horiszny of Orange County. Next slide, and I'll do introductions for each. Next slide. Kayla Heeekin works as the STI Prevention Program Manager at Essential Access Health. She has a passion for integrating harm reduction principles into sexual and reproductive health work and addressing root causes of health inequities. In her role, she manages the Chlamydia and Gonorrhea Expedited Partner Therapy Distribution Program, serving over 200 clinic sites throughout California. She also leads syphilis elimination activities with a focus on congenital syphilis. Welcome aboard, Kayla. Next slide. Bianca Clarke is a born and raised native Detroiter. She obtained her bachelor's degree in nursing in the heart of Detroit from Wayne State University. Her nursing background includes medical, surgical nursing, psych nursing, and emergency care nursing. But her love of public health nursing started when she served as a STI HIV public health nurse for one of Michigan's local health departments. She joined the Michigan Department of Health and Human Services Bureau of STI and HIV programs in 2020. In her current role as the Partner Health Improvement Coordinator, she works to enhance, expand, and strengthen expedited partner therapy as a treatment and prevention tool for sexually transmitted infections across Michigan. She also works alongside the Michigan Partner Services Program to assist with internet partner services and partner services processes. Welcome aboard, Bianca. Next slide, please. Kaitlin is the supervising public health investigator for the Orange County Department of Health. Prior to becoming the supervisor, Kaitlin was a program health investigator, disease intervention specialist at OCDOH for 5 years. Kaitlin aided in OCDOH COVID-19 pandemic response before transitioning into her role as supervisor in May of 2020, and now leads the sexual health unit for OCDOH. Kaitlin has 7 years of communicable disease investigation. Kaitlin created a chlamydia management program designed to increase timeliness of identification of priority chlamydia cases while utilizing the limited existing resources available, and is passionate about reducing barriers to sexual health care in the community she serves. Thank you, Kaitlin, and welcome aboard. And certainly last but not least, we have Kevin Horiszny. Kevin graduated from Vassar College in 2021 with a BA in chemistry and has past public health experience as an emergency department medical scribe. Kevin joined the Orange County Department of Health Sexual Health Unit as a public health fellow through the New York State Public Health Core Fellowships, and oversaw the development and implementation of the Orange County Expedited Partner Therapy Distribution Program. Thank you, everyone, and I'll turn it over to our speakers on expanding EPT initiatives.
Morning, everyone. Thank you for having us today. We're really excited to be presenting. My name is Kaitlin Cafferky. I appreciate the introduction of all of us. We are working on a collaborative effort, a multi-jurisdictional effort to give an overview of the different ways that we are trying to expand EPT initiatives, and hoping that everyone can kind of take bits and pieces of what you hear today and maybe implement it best in your local jurisdiction. We have worked hard on this project. I'm really excited to share it with you. Just a little background. Like I said, my name is Kaitlin. I'm from New York, and I was having trouble facilitating e-scribing for providers here in Orange County. I accidentally ended up in the inbox of a physician out in California who told me about Essential Access, and I started doing research and collaborating with some other programs and realized that we could do something similar in Orange County. I think that the hardest part of these initiatives is doing the background and research, and I'm hoping that in giving this presentation today, it can provide everyone with the tools that they need and also the contact information they need if they have any additional questions. So given the audience today, briefly, what is EPT? EPT is Expedited Partner Therapy, and it's the practice of treating the sex partners of persons with sexually transmitted infection without intervening medical evaluation or professional prevention counseling. This is obviously not our first choice, but is something that is helping us with our limited resources to try and combat these rising rates of STIs that we are seeing nationally. Next slide, please. Briefly, just an overview of legality of EPT. You can see here that mostly everything is green, and it's EPT is permissible almost everywhere. And the one thing that I do want to point out is that there's no red, so it is not prohibited anywhere either. There are some states that obviously still have potentially allowable in there, but for the most part across the country, practice of treating Next slide, if you could. A brief overview of EPT similarities in California, Michigan, and New York. Providers can dispense EPT without a laboratory confirmation. So with a clinical diagnosis, EPT is allowable when there is a high clinical suspicion. By law, there is no limit to the number of medications or written prescriptions that infected clients can receive for their exposed partners. Sexual partners within 60 days prior to the infection are considered the best candidates for EPT as they are at highest risk. However, in New York State, at least, you are able to give to the most recent sex partner, even if that partner exceeds 60 days. EPT may not be dispensed. EPT may be dispensed by medication in hand or prescription. EPT is not recommended for patients if they're co-infected with syphilis, and patients must be given informational materials to deliver to their sex partners along with EPT. So those are just some of the similarities that we found between all three states, and wanted to point them out as an overview of the laws within our jurisdictions. Next slide, please. EPT is so important because repeat or reinfection is common, and we want to find a way to effectively combat this. Most positive results are not due to treatment failure, but from reinfection. And this can be caused by an untreated partner, sex with a new partner, or their other factors could include sex before the patient completed adequate treatment, intimate partner violence, and other socioeconomic factors. Next slide, please. This is just a brief overview of some of the statistics surrounding reinfection in California, Michigan, and New York. So in 2019 in California, there were 237,000 cases of chlamydia, and there was about a 8 to 17% reinfection rate for chlamydia and a 5 to 10% reinfection rate for gonorrhea. In 2021 in Michigan, there was 46,265 cases of chlamydia and 22,166 cases of gonorrhea. And the reinfection rate for all counties and health jurisdictions ranged between 4% to 13%. In 2021, in New York State, this is excluding New York City. So when we're running data in New York State, we typically tend to exclude New York City as they kind of have their own data, which would kind of skew the rest of the look, which would skew the data a little bit if you were to look at New York City in conjunction with New York State, because they're such different demographic areas. So reinfection rate for New York State outside of New York City was 1.5% to 16.5%. for chlamydia and 3.1% to 25% for gonorrhea, respectively. And with that being said, I'm going to turn it over now to Kayla. Next slide, please.
Thanks so much, Kaitlin. So in addition to reinfection being common, it also has some dangers with it as well. This slide shows some of the occurrence of pelvic inflammatory disease and ectopic pregnancy if someone has a second infection or 3 or more infections. So it's important to know as well the risk of these complications with repeat infection. We can go to the next slide. So my name is Kayla Heeekin. I'm an STI prevention program manager with Essential Access Health. I use she, her pronouns, and we are a sexual and reproductive health nonprofit based in California. And a lot of our projects work in collaboration with the California Department of Public Health. And our mission is to champion and promote sexual and reproductive health care for all. We can go to the next slide. So one thing I wanted to touch on is medical legal considerations when it comes to EPT. This is one of the most common questions that we get is if EPT is legal and what are the legal risks associated with. So it's important to know that EPT is evidence-based and supported by national guidelines and within California state guidelines as well, and many other state guidelines. It's also supported by the American Medical Association, the American Academy of Family Physicians, the American College of Obstetrics and Gynecologists, and the American Society for Adolescent Medicine. And as well, in California and many other states, there is explicit legal protection from liability for physicians, as well as other prescribers. And newly in California as well, we have pharmacists are covered explicitly in the law. So important to know that there's a lot of legal protections for EPT, can vary state by state, but important to know that. We can go to the next slide. So as Kaitlin mentioned, the definition of EPT, also just important to consider as well that I look at EPT as well through the lens of harm reduction as it being an approach to cases where partners are unable or unlikely to seek care in a clinical setting, whether it's stigma for someone accessing a clinic, transportation barriers, somebody can't come in during clinic hours because of their job, so many different reasons that prevent people from coming into a clinic, but that doesn't mean that somebody's partners can't get treated. So just to know that as well. You can go to the next slide. So this model kind of goes through what the EPT method can look like. So EPT involves providing the index patient with the appropriate medication or a prescription, along with educational materials for an index patient's sex partner or partners. At an index patient's visit, the provider will treat the patient and also give treatment and educational materials for the index patient to give their sex partner or partners. Although writing a prescription is definitely an option for EPT, the preferred method is for the provider to give the medication directly for their partner or partners. This is particularly important in specific populations such as adolescents and young adults have been shown to be less likely to go and fill an EPT prescription for a partner than to give the medication to partners directly. Then the index patient delivers the medication or prescription to their sex partners or partner, along with educational materials. They can also fill that prescription themselves. And now the index patient and sex partners have all received treatment. We can go to the next slide. So this slide shows, I know there's a lot of data here, but shows the effectiveness of EPT in randomized controlled trials. This was prepared by the California Department of Public Health STD Control Branch and shows data from 5 different randomized controlled trials. The bars in the graph show reinfection rates based on patient referral, use of expedited partner therapy, or having patient referral and educational information for the partner. The first two studies were done with a focus on chlamydia. The second two focused on chlamydia and gonorrhea. And then the third was focused on trichomoniasis. Important to note that in the first four studies, showed that EPT reduced reinfection rates for those who received EPT versus just patient referral alone. Also noted reinfection rate when there was patient referral and information for the partner could be also effective in supporting reduced reinfection. One thing that's important to note is that for the study related to trichomoniasis, EPT did not show the same level of effectiveness. EPT is an option for trichomoniasis, but based on this randomized control trial data is part of why our particular program focuses specifically on supplying medication for chlamydia and gonorrhea because of the known effectiveness. You can go to the next slide. So in the state of California, as of February 1st of 2020, EPT became a covered benefit for Family Pact and Medi-Cal, which is our state Medicare program, recipients who test positive for chlamydia, gonorrhea, and trichomoniasis. This can be covered either through giving medication directly to a patient or providing them a prescription. And it's important that they know that the prescription is billed to that particular index patient's insurance. So to their Medi-Cal, it's considered a way to prevent reinfection. So that's the justification of being written in that way. And while there's no limit legally to the number of EPT doses that can be written for a patient in general, in the case of Medi-Cal and Family Pack coverage, there's a limit to up to five partners covered, plus the index patient's own treatment. This was really exciting for us, though, to provide kind of an expansion to offerings of EPT in our state. You can go to the next slide. So here is a chart that just shows the difference between first-line treatment and EPT, the medications that are used. So the STI treatment guidelines were released in July of 2021 and included some modifications for chlamydia and gonorrhea. The recommended treatment for chlamydia infections is doxycycline, 100 milligrams twice a day for 7 days. And for pregnant patients, the alternative treatment is azithromycin, 1 gram orally in a single dose. For EPT, in our particular program, we offer both options, doxycycline and azithromycin. There is some providers who have a preference for offering azithromycin also for when they have concerns about medication adherence, but available evidence supports that doxycycline is more effective in treating chlamydia infections in urogenital, rectal, and oropharyngeal sites. So it has a high efficacy for urogenital infection among women, but there's a concern regarding the effectiveness for concurrent rectal chlamydia infection, which can be common and may not always be predicted by reported sexual activity. So those are some considerations there. And for gonorrhea, we have ceftriaxone 500 milligrams intramuscular injection once. And for EPT, we have cefixime 800 milligrams orally once. If in this case, if chlamydia infection has not been excluded, they can be treated with this oral dose plus doxycycline, which is a shift from dual treatment that was used previously. And a test of cure is appropriate for pregnant patients with chlamydia 3 to 4 weeks after initial treatment, and any patient with pharyngeal gonorrhea 7 to 14 days after initial treatment. However, because testing at 7 days could result in increased likelihood of false positives, it should be done closer to 14 days when possible. You can go to the next slide. So now that I've given a little bit more background on EPT in general, I'm going to dive into Essential Access Health's specific chlamydia and gonorrhea EPT distribution program. So our program was established in, we can go to the next slide, sorry. Our program was established in 2005. We started providing chlamydia treatment in California. We expanded to include Cefixime for gonorrhea in 2021. And we distribute medication to over 200 clinic sites throughout the state of California. We can go into eligibility. So some of the eligibility requirements we have is that each clinic site or local health jurisdiction needs to be located in California, serve a population that's at risk for STIs and that is uninsured or underinsured, have to demonstrate an inability to purchase and repackage medication, and need to be sure that they provide index patient treatment for chlamydia and gonorrhea with no out-of-pocket cost to the index patient. We also have introduced a requirement that if the option is there for patients to receive medication through Medi-Cal or Family Pack, now that it's a covered benefit, that be used as a first path to accessing medicine before our free safety net program. You can go to the next slide. So some of our participation requirements, we have a webinar for our program that needs to be viewed when sites sign up and whenever it's updated. Distribute medication as appropriate and only use medication at the specific assigned sites. Provide patient educational material and clinic referrals with every single dose. And we offer patient education materials on our website, our resources page, which can be used for all of our sites and also can be relevant for other programs. You require that sites keep a medication log, and as I mentioned, must bill Medi-Cal and Family Pack when it's feasible. So that's kind of the quick run through of our program from Essential Access Health. I'll drop my email in the chat if folks have any questions, and can also have questions at the end, but I'm going to pass it over to Bianca.
Right. Thank you, Kayla. And we can go to the next slide. Again, as Kaitlin mentioned and Leo mentioned, my name is Bianca Clarke, and I am the Partner Health Improvement Coordinator for the Michigan Department of Health and Human Services. And I am going to discuss the pilot project that helped to facilitate access of expedited partner therapy to patients seen in Michigan emergency departments. Next slide, please. So here we just have the background, purpose, and methods. Because the data has shown that emergency departments are often healthcare access points for patients with complaints related to sexually transmitted infections, and the research also shows that repeat infections are often due to untreated partners, we wanted to embark on this project to ensure sexual partners received STI treatment as a standard of care. So with that, the purpose of this pilot project, again, was to expand the use of expedited partner therapy in Michigan emergency departments through a public-private partnership. The methods that we use, MDHHS created all-inclusive medication packets for partners of ED patients diagnosed or presumptively diagnosed with gonorrhea and or chlamydia. Essentially, we created 2 packets, one for non-pregnant female and male partners, and then the other for pregnant or possibly pregnant partners. We partnered with 3 urban hospital systems to distribute packets to eligible patients at no cost to the hospital system or clients. Next slide. So here we just have a rough timeline of the project. In the interest of time, I'll kind of go through these quickly. So in 2019, the objective to distribute EPT packets in high incidence communities was added to our CDC PEACH grant objectives. In late 2020, I was hired on to take over the project and develop the project. By early spring 2021, we had buy-in from 2 emergency department sites. And then by mid to late summer, they were ready to receive packets for distribution within their ED. By February 2022, we had buy-in from our 3rd site, and they launched the project shortly thereafter. Next slide. So I know the slide is busy, but here I just have a few more detailed site-specific timeline for folks to be able to review. This timeline just contains a few components that were specific to each site, including one site wanting to do an IRB approval, the specific launch dates, the demographic areas that were serviced. And then I also have just some information about the timeline needed to educate ED staff, nurses, residents, interns, and physicians. So this was just a rough timeline for each site that I put together for you all to view. Next slide. So just a few more project details. Again, the project was funded using PEACH or CDC supplemental grant funding. The medications, they're ordered in bulk. And then just to give some process to how we do our medications here in Michigan, but they're sent over to our contracted pharmaceutical repackaging company. Once the medications reach our the bulk medications reached our repackager, they put the medications into appropriate individual or unit dosages needed for adequate STI treatment. So for example, we send over the bulk Cefixime and then they repackage it into that 800 milligram single unit dose or those 2 tablets that folks need. Again, with the azithromycin, that 1 gram, they put them into two tablet dosages. And then for the doxycycline, we actually give our clients a 14 tablet 7-day supply in a bottle. We purchased the medication at wholesale pricing. So we do not get any 340B special pricing for the medication used for this project. And then I also wanted to mention that all 3 sites utilized or will start to utilize BPA or best practice alerts, which they tailored and developed the physician and pharmacy staff for their specific electronic medical records or EMR systems. And a BPA just reminds the provider that the kits are packets. So I'll use that terminology interchangeably, but it just allows the providers to know that the kits or packets are available and should be used for those individuals who are presumptively coming into the emergency department to be treated for a possible STI. Next slide. So here we just have the packet contents and description. So the packets are meant to be discreet. So we use a white opaque Mylar expandable bag with the dimensions of 6.3 inches to 9.4 inches as the dimensions. Inside the kit are EPT patient and partner information sheet. We have 1 to 2 condoms and a single-use water-based lubricant as harm reduction. On the outside, we have a QR code, and that just directs partners to an EPT YouTube video that MDHHS created. Also located or stapled on the outside is a half slip of paper, which is for the index or infected client to kind of rip off. And it just goes over how to tell your partner. So how to start that conversation about the packet with your partner, how to terminology they may need to use and things like that. Due to the likelihood of co-infections, we opted to treat for both chlamydia and gonorrhea with these packets. So for those non-pregnant female and male partners, they will get a bottle of doxycycline for that 7-day dose. and then they'll get the 800 milligrams of Cafferky. And then for pregnant or possibly pregnant female partners, they can get the 1 gram of azithromycin in a single dose. And then they'll also get the Cafferky 800 milligrams. Just some tweaks that our sites made to their packets. Site 1 actually removed the harm reduction, so they didn't want the condom and lube. They also added some additional stickers to the outside of the package. Site 2 added prep pamphlets to the inside of their packet in October. And Site 3, they just utilized the kit as is. Next slide. So here's just an example of the kit contents again. As you can see, they are color coordinated for easy distribution for ED staff, since we know they're extremely busy. Again, on the outside, I'm sorry, it's just not the best picture now that I look at it in real time, but on the outside, you'll see that purple half slip. And again, that's to kind of go over how to start the conversation. So it's for that index patient to rip off and just kind of review before giving the partner the packet. That QR code again is on the outside, and it was a video that we made, and it goes over that specific packet and what medication is in the packet. We have 2 different QR codes so we have a QR code for those, the males and non-pregnant females, and then we have a QR code for pregnant females as well. We also have you can see here the medication itself. And then on the back of the packet, we have the pharmacy information, so that the emergency department pharmacy folks don't have to dig through the packet. They're able to see right on the outside the lot numbers, expiration date, and NDC numbers for the medication. And again, on the inside of that packet, we have the partner and patient information along with that harm reduction of condoms and lube. Next slide. So here's just that half sheet that I've been talking about that doesn't look so great either. So if folks need it, my contact information, I can drop it in the chat, and you guys can ask me for it if you want to see it. And we also have pictured here just the EPT guidance for healthcare providers and pharmacists. And this is just a document that we use for pharmacy and physician staff across Michigan that talks about the EPT laws here in Michigan. Next slide. So EPT kit distribution across our 3 emergency departments. Site 1 dispensed 11 packets from July 2021 to October 21. Unfortunately, during that time, we lost our EPT physician champion. She moved to New York. And we tried with the existing pharmacy staff to kind of relaunch the project, but they even had pharmacy staff changes once she left. So the project currently with Site 1 is suspended, unfortunately. But for Site 2, they were able to dispense 46 packets between January and November. And then Site 3 dispensed well over 60 packets from February to November. Next slide. So when we started this project, we had the pharmacy and our provider EPT champion commit to doing minimum data requirements and monthly check-in meetings because we wanted to learn from the project and help other sites if they ever wanted to start up EPT projects of their own. So we asked pharmacy staff to give us minimum data requirements on a monthly and eventually quarterly basis. So some of the things that we asked for are just like the number of packets, if one or more patient received more than one packet, the ages of the clients, gender, type of insurance, number of providers who dispense the packet. So within these facilities, they wanted to see if the same providers were given the packet versus different providers, which just kind of allowed them some process improvements in case they needed to do provider education again, if they were seeing that the same folks were the only ones given the packet. So that was something more of a facility type of data that they wanted to collect. We also look at the client zip code. And again, another process improvement for the site is if the client subsequently tested positive for an STI. So just some retroactive data utilizing those labs that were drawn while that client was doing that ED visit. We do not collect any personal identifiable information, PII or PHI, which is protected health information on behalf of this project. So the sites also wanted to learn from the project as well. Again, they looked at that retroactive data. They looked at what providers were giving out the packets. So they have in turn recruited additional staff, residents, and interns, both on the pharmacy and physician side, to monitor the data collected from this project. Next slide. So just a little bit more of project data and results to date. From June 2021 to November 2022, 150 standard EPT packets and 35 EPT packets for pregnant partners were designated for ED EPT purposes with this project. Again, Site 1 was suspended, but the majority of clients who received EPT packets ranged in ages 18 to 54. Site 2, they're going to expand the EPT packets to their on-site OBGYN clinic and urgent care. And they have given out the packets to people as young as 15, their age ranges from 13 to 40 years old. And they've had over between 15 to 18 different providers give the kits on a quarterly basis. So that's good. And Site 3, they've had the highest amount of kit distribution. They just so happen to also reside within one of our high incidence areas for STI infection rates in Michigan. And they've had over 22 different providers prescribe the kit. And clients who received EPT for their partners ranged in ages from 19 to 55. And looking at their retroactive data, within this most recent quarter, over 50% of the clients who received a packet also tested positive for an STI. Next slide. So just some project challenges. In 2021, there was a nationwide suffixing shortage. Contacting ED staff during COVID was challenging. Securing those ED sites during COVID was challenging. Obviously, with Site 1, maintaining a permanent EPT champion. Some of the pharmacy regulation we had to get around. Some of the sites preferred electronic pharmacy records versus a physical copy, or T3 is what they call it. That's a pharmacy term. It means like transaction history. It's like the custody chain for the medication. So some of our first site wanted that electronically and electronically only. So that was some things that we had to kind of create workarounds for. By the state health department not being a licensed pharmacy, even though we have approval through 340B under HRSA to operate under the centralized distribution model, we still had to get those pharmacy folks comfortable with the fact that they were getting their meds from the state health department, essentially. Unit dosing, packaging is only good for 6 months. Therefore, small batch ordering is best to avoid medication expiration. This is just something that we couldn't get around. So every 6 months, I shouldn't say every 6 months, I have to be very cognizant when I'm ordering back to back because the medication can expire. Also, IRB approval. One of our sites is affiliated with a university, and they wanted to do provider and patient surveys to study the project, so they require an IRB. And then we have within our hospital systems BPA, provider fatigue. This is a reoccurring theme for ED providers outside of this project. So they get prompts all the time while charting to help with a multitude of illnesses, disease processes, emergency protocols for clients that utilize the emergency department. So it's something to be cognizant of, that those providers can get fatigued if they keep getting those BPA alerts. Next slide. Project facilitators. Allowing the provider and the physicians to take on the role of educating staff was a great tool to utilize. EPT champions having a good knowledge base of what EPT is up front before we start the project. So I had to have those conversations in the beginning. The adaptability of the healthcare electronic medical record system. So them being able to tailor to the needs of the project. If the project changed, that was an amazing thing to see unfold. Our monthly check-in meetings were really great. And then also knowing, once these projects got started, knowing that pharmacy staff needed to be a part of those conversations and not just physicians, and them working together to build out those EMRs. So we also learned, because of that, we had to also quickly implement EPT paper scripting in case there was a kit or medication shortage. And also, again, just that monthly data sharing allowed for rapport building and relationship building with the state health department and ED sites. So the project continues to evolve, and we're continuing to learn more and more. Next slide. So what have we learned? We've learned that permanent physician and pharmacy staff are ideal. Provider education and re-education is probably needed every quarter. BPAs can be your friend if they're executed appropriately. If offered, clients will utilize the EPT. So that's a big, strong lesson that we learned. Areas with high STI incidence and ED visits for STIs may yield higher packet distribution. Again, pharmacy and physicians must work together from the beginning of the project. After 6 months of the project's implementation, staff can be transitioned from monthly check-ins to quarterly. This project was able to be started remotely due to COVID restrictions. Having both the paper and the actual packet available, or paper scripting and the packet available, is desired. When we talk about authorship or credit, if you plan on implementing projects with physicians, they love to write articles and papers. And now that the criteria for authorship has changed to include people who have the idea for the project, it's just a good thing to think about when you're partnering, because authorship can give you a great opportunity to bring recognition to you or your organization and the work that you do. So I want to close at least my portion of the presentation to just say that EPT is an amazing tool for partners. We know that the best partner treatment approach is one that gets the partner treated quickly and accurately. In a perfect world, we would love for all of our STI patients to receive that traditional partner interview. But in the absence of an interview, we recommend that providers utilize all partner treatment options, including EPT. And next slide, please. And that concludes my portion. And I am going to pass it over to Kevin and Kaitlin from New York.
Thank you, Bianca, and hello again, everyone. I am going to try and be quick and timely. We ended up here after, consulting with California Essential Access and also Michigan. We ended up with our own program for EPT distribution. Next slide, please. So in New York State, providers are able to provide EPT via med in hand or through a prescription. I actually was working on an incentive that the state had put out to do public health detailing with providers, and I was trying to facilitate EPT through e-scribing and kept coming up on barriers. So I was lucky enough to sit down with the EMR specialist from one of our local healthcare practices, and once we were able to develop a dummy chart for EPT, it was like, well, how many providers are going to be in here? How can we link this back to the original patient? There was just a lot of issues that we encountered. So I started thinking, how can I remove these barriers for providers? We already always talk about the barriers that patients have, but how can we help remove the barriers for providers to increase the amount of EPT provided within our county? Next slide, please. And there's just a couple of bullets if you could continue to click. So there's an evident need for EPT in Orange County to help with just the sheer volume of cases that we see and our limited resources. So this is just a brief overview of the amount of cases that we see. On average, we see about 1,400 cases per year. And apologies, this is an old slide. That's the 2022 year-to-date data. It's just still preliminary. In addition to roughly about 300 cases of gonorrhea and over 120 cases of syphilis, and there are 3 people that can respond to all of that, and it's just simply not enough. We also have an above-average reinfection rate when compared to New York State. So we have high disease burden, and we start to talk about the harm to reproductive health and increased risk of contracting additional opportunistic infections. And as has been mentioned before, EPT has been shown to reduce the rate of reinfection and transmission and increase partner notification, and also increase education and reduction in risky behavior. Next slide, please. So some barriers to EPT specific to Orange County. Barriers for our providers. EPT is exempt from the e-scribing mandates, but few offices carry or are willing to use paper prescription pads. So, when you have a large healthcare group or a large urgent care and you're getting one pad for the entire healthcare facility specific for EPT, where do you store it? These are the questions that we were getting pretty regularly, and they're good questions. There's a lot that goes into the logistics of providing EPT that sometimes I think we can forget. E-scribing platforms do not allow for no-name scripts, so when you are offering EPT to someone, and even though you are allowed to be able to provide the script with no name, you can't actually do that in an EMR. So once you build the EPT profile, then how do you link? I went over this a little bit, but how do you link it? And then you want to really be careful to not have PII in a chart that can potentially have multiple providers accessing it. So if you created a dummy profile for providers to be able to prescribe EPT from, do you do it for each individual provider? It gets very confusing. Pharmacists are often underinformed, and they're less likely to fill a no-name prescription. So through this program, the EPT distribution program, we eliminate pharmacists and pharmacies completely, other than the one that we've contracted with to provide the medication to us. Double prescribing for one patient is insurance fraud, and we were actually kind of alarmed at the amount of times when somebody did say that they provided EPT, how often they were actually doing this through double prescribing, and made sure to provide some education as soon as possible to explain that it was insurance fraud and why. And the cost to purchase medication for Med in Hand deters medical practices. So we did all this public health detailing, and then it was kind of like, well, who pays for this then, right? You can't double bill, and where does that responsibility lie? So that was the barriers for the providers are really what made us start to think of another way to facilitate EPT within Orange County. Briefly, the barriers for patients and partners are usually pretty alike, I think, universally across the board. So if an index patient is going to fill an EPT script, they would have to then assume the cost. And if the EPT script is given to the partner assumes the cost, and who knows what their insurance can be. And I think that rates can vary, but sometimes you're looking at like $60 to fill Doxy, which can be pretty expensive for people. Patients and partners can have difficulty even getting to the pharmacy. So you're talking about not only the cost of filling the prescription, but also the cost of getting there. And adolescents have difficulty filling a prescription discreetly, and minors have rights, but it's really hard for them to sometimes access things even with their rights because of some of these barriers that we just discussed. Next slide, please. Just kind of an overview of our program goals. So we are looking to reduce the incidence of chlamydia, gonorrhea, and trich in Orange County, including our reinfection rates, decrease the barriers to prescribing and accessing EPT, make EPT readily available to providers and to patients, and create more favorable health outcomes within our community. Next slide, please. So we wanted to, there's just a little bit more content on this slide, if you could click. We wanted to make sure that we were pretty open with our eligibility requirements. So we briefly just described it as clinics located in Orange County serving a population at risk for STIs. We included urgent cares, emergency rooms, sexual health clinics, and OBGYN clinics. For the patient and partner eligibility requirements, our eligibility index patients with uncomplicated chlamydia, gonorrhea, or trich. and this can be a clinical or laboratory diagnosis. Ineligible index patients would be a co-infection with syphilis, so we're still highly prioritizing our syphilis investigations and referring any patients in. We want those patients to be referred in for further evaluation. We want to be able to know what those titers are, if they're preventatively treated, or if they're, sources and spreads. That's really a high priority for us, especially when you're talking about the congenital syphilis and the rising rates that we've been seeing. We also included victims of child abuse, sexual assault, and intimate partner violence as ineligible index patients. We really didn't want those people to have to be in the position that made them feel uncomfortable. Eligible partners are all partners within 60 days or the most recent partner, and we described pregnant persons as ineligible partners because we really want those patients to be referred in for more further evaluation, care, maybe linkage to prenatal care, etc. So it was really kind of an opportunity for the provider who would be providing the EPT to have that conversation if the partner is identified as a pregnant person to, refer them, make sure that that referral is made to get the partner into care. Next slide, please. So we have this idea after we meet all of these, I had this idea after we met all these barriers and trying to do the e-scribing. So it started out with a lot of research and an overview of funding sources. So something that we haven't really touched on yet is 340B. 340B is not appropriate for situations where medication is not being provided directly to our clinic patients. So 340B funding has some really tricky language. So what we had to do was find a funding source first and, come up with a project outline and before we could start implementation. So we did our research and we got a quote collection. I think that someone had mentioned the cefixime shortage, which was a problem for us when implementing this as well. Many repackagers are unwilling to handle penicillin. So even though the cefixime shortage was happening, we still wanted to make sure that when the shortage was resolved, that we were able to include cefixime within our partner packs. Ultimately, we ended up contracting with Remedy Repack, which I believe is who everyone else on this call is working with as well. I know that we've been helping New York City, and they're kind of doing the same type of implementation program, and they're also working with them. Remedy has been great to work with. We used our incentive funding to support this initial rollout of the project, and we're hoping to collaborate with New York State for sustained funding. So once we got all of these things in place, we did our research on our quote, we had to do some partner recruitment. We partnered with our local federally qualified health center as well as our 2 local emergency rooms who had showed previous interest. So prior to doing all of the research, I also recommend that you identify partners because it would be a shame to do all of the work if you don't have anyone that's going to partner with you on this. Next slide, please. So after identifying our partners and doing all of our research, we established a way to order through a Google form, and each site is required to have one designated point person that then works directly with Kevin, who manages this program. Kevin also is responsible, the point person, for distribution to clinics. So the packs are ordered and then delivered via collaboration between Kevin and the established point person at the participating partner sites. We have a log that we require to be kept and updated to include just basic information, and participating sites are required to submit the log to us quarterly, and ordering is also done on a quarterly basis. We didn't want to get in the habit of ordering every other month depending on clinic site. We wanted to kind of have it established across the board as a precedent. Specifically, we included in our packs antibiotics, educational materials, medication instructions, clinic referrals, color-coded packaging, and we added an option for personalization. So antibiotics are labeled on the outside, which we'll look at in a little bit. Education materials are required by New York State as part of the EPT law, so to eliminate that barrier of kind of having for the healthcare provider that's providing this to have to find those materials, because that can be another barrier too. Everything is included, and this pack is really ready to go. We included our clinic cards because EPT is a tool because of the limited resources and the high burden of disease, but it's not, like we have been saying, the number one approach. It's kind of like where other things are not available, this is our backup plan. So we also, in collaborating with our partners and talking to our partners in advance, decided to go with color-coded packaging. 2 of our partners are emergency rooms, and we wanted to make sure that this was as easy for the providers as possible. So we have a certain color for chlamydia, a certain color for trick, so on and so forth, which actually is in the next slide. If you could go to the next slide, please. So this is a look at the contents of our packs, as well as the colors of our packs. Like I said, we wanted to make this provider friendly, so not as discreet as Michigan, which I think is really great, but we wanted to be provider friendly as well. So hopefully it's discreet because it can fit in your purse or your backpack, but they are color coded to try and eliminate any confusion, including the education materials, the medication instructions, etc. Next slide, please. So we also want to make sure that what we're doing, is effective and is creating a sustainable change. So we have some performance measures that we're monitoring. So we have baseline data that we collected from Cornerstone, Garnet Health Medical Center, St. Luke's, which are our 3 partners at this moment. We are looking at the 2020 data currently to review who else might have been a top diagnoser within Orange County to see if we can expand our partners. We are looking quarterly at the data, reviewing the EPT performance, and we're looking to enhance our understanding in epidemiology with patients and demographics and quantities of each package type distributed. We're also looking to expand the program, especially into more large group practices. We are also, while we are Orange County Department of Health, we are not giving any, there is no residency requirement to live in our county. It's just that we want our providers within our county to be able to provide this service. So even if someone from a neighboring county, neighboring state, because we're in the tri-state area, is diagnosed, we are still including them as an eligible person for EPT. And next slide, please. So that wraps it up. And before I take questions, I just want to ask if we have time for questions.
Thank you so much for asking that. What we will do, just in lieu of time, we will take one question. I think, Jerica, if you can come off mute to ask that question, and then we'll ask our partners from California, Michigan, and New York, if you don't mind, to just check the chat for any additional questions that you can respond to.
Yeah, thank you for your presentation. We had a few questions around one central theme, so I think it may be a good idea to ask this one. But is there anything that you can say around hesitancy or resistance, either from pharmacists or different clinicians, around resistance around EPT due to liability issues or just hesitancy around EPT in general? Are there any suggestions or strategies that any of you can provide for that?
I can speak to that a little bit. So in California, we have had, I'm sure all states have experienced this, but we have had provider resistance and also, pharmacist resistance or like need of education. One thing we've been doing is expanding our pharmacist education efforts on EPT. So we have a FAQ for California pharmacists resource on our website, and also are going to be we've done one webinar for EPT education for pharmacists and are going to be doing another one in March, and trying to partner with our our California pharmacy partners to offer continuing education for pharmacists to attend. I think a lot of it is just lack of awareness and lack of awareness around the law, or language can be confusing between pharmacy law and EPT law. So I think that that's one piece. And then when it comes to provider resistance, one of the things that I've found to be most effective is within a clinic site or within a organization, identifying one provider champion or one staff champion and coming in with them and doing provider education or trainings with an emphasis on liability. So that's why I always try to include the medical legal considerations and liability as part of the conversation up front, because I think that that's one of the biggest things that we get questions about. But many, I will say, we didn't have explicit legal protection for providers in California law until recently. But I will say in researching the laws throughout the states, there are many, many states who do have explicit legal protection for providing EPT. So I would say, researching your state laws and always including that in trainings as a way to center it.
Awesome. Thank you so much for that response. Once again, thank you so much to our colleagues coming from the great state of California, Michigan, and New York for this great presentation on EPT. Just as we get ready to go into break, just want to remind people to continue to put your questions into the chat and for the presenters to continue to respond to them. Given that we are a little behind on lunch, we will break now, and I will ask everyone to return back to the meeting link at 1:45 p.m. and we will resume then. As always, if you have any questions, please let any NCSD staff know. If you had some technical issues with getting into the breakout rooms, but nevertheless, we will get an opportunity to try this again when we do breakout rooms later in the day. So hopefully by then, everyone will know which buttons to click. Also, there will be less rooms to pick from, so that should help as well. As we move forward today, we are going to move into collective care with a couple of presentations. Our first presentation is with the Sacramento County Public Health with Krystal Bell and Tiara Johnson. And by way of introduction, here are their bios. Krystal Bell, MPH, CHES, PMP, works as a program planner at Sacramento County Public Health in the Sexual Health Promotion Unit. Her work involves using qualitative and quantitative data to create innovative and integrated solutions for improving sexual health outcomes in Sacramento. Krystal's passion for sexual health is driven by her childhood history of seeing sex-positive dissenter. She hopes to create a future in which BIPOC members are given the space to express their sexuality freely and can live their best sexual health lives. Professional highlights include creating a county-wide youth advisory board, leading an evaluation project to assess the reach and effectiveness of a regional media campaign, and always finding ways to include Beyonce into her work. She hails from St. Louis, Missouri, but has spent most of her adult life in California. Her undergraduate work in American Studies was completed at Occidental College, and her MPH was obtained from the University of Alabama at Birmingham. She is also a member of California's Adolescent Sexual Health Work Group. Tiara K. Johnson, MPH CHES, is a double Eagle graduating from Georgia Southern University with a Bachelor's of Science in Biology and Master's of Public Health. Tiara joined the Sexual Health Promotion Unit at the Sacramento County Division of Public Health in July 2020. As a health educator in December 2021, Tiara transitioned to the role of Health Program Coordinator of the HIV/STD Prevention Program. As the Health Program Coordinator, Tiara leads the team of inclusive and diverse health educators. Fundamentally, they work to prevent HIV and STD prevention in Sacramento County. However, the essence of the job is to advocate for changes to eliminate structural and institutional barriers and policies that negatively impact Black, Indigenous, and people of color communities. In addition to her full work as a sexual health advocate, Tiara assists with Port City Basketball Academy with Lincoln Health School basketball programs and is a member of the National Association for the Advancement of Colored People, Stockton branch. Everyone, Krystal and Tiara, thank you.
Next slide. Thank you. Thank you for the introduction too. Hi, my name is Krystal Bell and
my name is Tiara Johnson.
And welcome to our presentation about collective care. Next slide.
So as we begin this presentation, we express our gratitude and our appreciation of the original inhabitants of this area, the Nisenan and Miwok peoples. So we recognize and respect them as traditional stewards of this land. We are also cognizant that we cannot separate the history of our community from the history of slavery in the United States. We acknowledge the legacy of slavery in this area and the blood, sweat, and tears of enslaved people that soak the earth beneath our feet. These legacies, both in our land and labor acknowledgements, persist today as we continue to work towards racial justice, equity, liberation, and community. Next slide, please.
Tiara and I are both from Sacramento County Public Health's Sexual Health Promotion Unit. Our unit works to provide comprehensive sexual health services through 4 programs. We have a Ryan White Care program, which provides HIV-related services for folks who do not have sufficient healthcare coverage or financial resources for coping with the HIV disease. We have a sexual health clinic, which provides free and low-cost STI testing and treatment for the community. In addition, our sexual health clinic provides family planning services, contraceptive services, and linkage to care services. We also have an HIV/STD prevention program, which is headed by Tiara. And this program uses community-based testing, outreach activities, promotional campaigns, trainings, and other educational programs to prevent the spread of STDs. And then finally, we have our amazing HIV/STD surveillance program, which works to provide comprehensive STI services through education, access, case investigation, and other partner service activities. This team is made up of a number of communicable disease investigators, also known as CDIs, which are known across the country as DIS. We also work very closely with a number of community-based agencies to administer sexual health services to communities that may not otherwise have access to sexual health care. Many of the tools and practices we discussed today are used across all or not if some of the 4 programs. Next slide.
So by the end of our presentation, participants will learn about collective care and its importance in the workplace as a strategy for reducing burnout, be able to describe activities and tools used to create a culture of collective care, and identify at least one specific actionable item they can take back to their organization to help with building a culture of collective care. Next slide.
We want to begin our presentation today by defining burnout and illustrating the impact it is having on our workforce. The World Health Organization defines burnout as a syndrome conceptualized as resulting from chronic workplace stress that has not been successfully managed. And it describes 3 dimensions of employee burnout, which are listed on the slide. When employees are burnt out, they feel depleted or exhausted. They may have feelings of negativity towards their job and or don't feel confident in their ability to perform work-related tasks. For us who work in sexual health, we know how important it is for staff to feel comfortable, connected, I should say, to the community that they serve and feel confident in their ability to offer resources and provide services. Burnout is a widespread problem, and we cannot ignore the impact it's having on employees, clients, and organizations. And we just want to ask you all, what percentage of U.S. workers do you all think sometimes experience burnout? And please drop your guess in the chat. We just want to see if folks are aware. Someone put 100%, 75, 50, 35. All righty. See some guesses. And some people are spot on. The Gallup has discovered recently that 76% of employees experience workplace burnout, at least sometimes. That's a big number. That's almost 3 out of 4. Actually, that's more than 3 out of 4 employees. According to those stats, we may have to start asking ourselves, not if employees within an organization are going to burn out, but when, because it's almost inevitable. So it's really important that we look at causes of burnout and how to prevent and address it. Next slide. Thank you. The causes of burnout can occur at organizational, interpersonal, and individual levels. Employees in a 2018 poll identified 5 organizational factors of burnout, and they're listed on the slide. The first one was unfair treatment at work. So this can include bias, discrimination, favoritism, and mistreatment, and other kinds of workplace issues. The next one was unmanageable workload. This is when employees feel that they have too much to do. And then there was the lack of role clarity. So this is when employees aren't provided with the information they need to do their job. There was the lack of communication and support from their manager. So this looks like a lack of feedback from managers, and or if employees don't feel like their supervisors got their back. And then the last one was unreasonable time pressure. So this is when employees don't have enough time to complete tasks and are constantly working under pressure. To fully address burnout, organizations need to adopt strategies that improve their organizational culture and climate to prevent these drivers of burnout from occurring. Today, we're going to discuss collective care and how it can prevent and manage burnout. Next slide.
So what is collective care? So our interpretation, it is a practice of building and strengthening the well-being of the entire community. It complements self-care and advocates for communitarian ideas in the workplace. So self-care focuses on the individual, while collective care encourages us to see well-being as a shared responsibility of the wider group. So some benefits of collective care include social support, community, collaboration, well-being, and security. Next slide, please. So this practice in some form or another is starting to pick up steam in our workplaces. Yet there can be some barriers to creating a culture of collective care in the workplace. What do you think some of these barriers are? So if someone would like to drop 1 or 2 in the chat of what they think the barriers to collective care are. Okay. So time and cost, resources, manager buy-in, racism, they are coming in very fast, but yes, those are some very good answers. So some common barriers are cost, time, budget constraints, organizational rules, fear of employees not working, and stressful to organize. So many leaders feel as though they're between a rock and a hard place. They don't want their employees to get burned out, yet they need to inspire higher productivity and performance. Next slide, please. So here are some tips and tricks that organizations can use to promote a culture of collective care. So number 1, get buy-in from organizational leaders and staff. Improving burnout requires system and organizational level solutions. We must educate our leaders about burnout and use data to show its impact on staff. Number 2, choose one thing to work on at a time. You can't change everything at the same time. We just need to take one step at a time. Number 3, be creative. Culture change takes time and resources. Some of our departments, or I should say all of our departments, are understaffed and sometimes underfunded. So we have to think differently about how to build supportive communities and spaces on a dime with limited resources. Number 4, give each other grace. Don't stress about de-stressing. Understand that things take time and we need to extend grace and patience and practice patience as things change and shift. And number 5, tailor this to your organization. Next slide, please.
We tailored this practice for our team by focusing on these elements of collective care. And I just want to point out that we are by no means perfect. And we are not experts at collective care. We struggle with employees feeling burnt out, just like other organizations across the across the country in this field, and we are constantly looking at ways to improve employees' experiences within our workplace. So some elements we focus on include enlisting help. This includes us getting assistance from employees, leaders, and community partners to help create activities, policies, and protocols geared towards collective care. For us, this meant asking leadership for more positions so that we could be appropriately funded. This is still a work in progress. This also includes us talking with employees to help identify existing workloads and improve efficiency. Another element includes us establishing a supportive community amongst coworkers. So that's making sure everyone feels supported, valued, and respected. That is a tenet of collective care. Encouraging joy. So that means letting folks know it's okay to have fun at work. Laughter helps support a positive well-being. Another one is exercising empathy. So we find ways to better understand our target population and their needs. This helps connect folks to their work. And last but not least, we try to focus on trying to evaluate burnout and measuring progress. There are formal ways to measure burnout in the workplace, like the Maslow burnout inventory or conducting a needs assessment about the drivers behind burnout at your organization. We focus more on informal and low-cost ways to evaluate burnout and measure progress, such as just checking in with employees regularly, creating action items, and then monitoring to see if things are getting better or worse. There are also some tools we use to cultivate an environment of collective care, and those include asynchronous and synchronous communication, DEI activities, and outreach and engagement activities. And we're going to talk more about those tools now. Next slide. Positive communication in a workplace can boost employee morale, engagement, productivity, satisfaction, and relationships. A part of collective care is building and sustaining a positive community. In a positive community, folks feel supported. They feel they are connected to their work and team members. Positive nonverbal and verbal communication can be used to create a positive culture centered around community and connection. We talked earlier about contributors of burnout. Well, with communication, obviously followed by action, these causes of burnout can be addressed. We can use communication to assess workloads. Ask employees, what's a comfortable work pace for you? Do you have too much work? What are some barriers to accomplishing those tasks? We want to strive towards folks working at a pace and with a load that is comfortable for them. We also want to have conversations about job expectations. In a positive environment, folks are able to work in roles that have flexibility and allow them to exercise their strengths or talents. And like I said, we're striving for progress, not always perfection. So we're still working at this. So we do need to have conversations about what folks are good at, what do you like to do, and we can try to craft jobs to fit employees so that they can perform better. With asynchronous communication like emails and synchronous communication like meetings, we can create workspaces in which folks feel supported, respected, and valued. On this slide, there's an example of an email an employee sent to another. It was a shout out, thanking them for their work. Something so simple can mean so much to people. Next slide. In our unit, we host regularly scheduled unit, team, and one-on-one meetings. These meetings are held to ensure that folks have a space to feel heard, seen, and supported. It's also a place where the needs, talents, and capacities of employees are centered. A big part of collective care is the team taking care of the team. In our work, we often see difficult client cases and situations like frequent flyers. And with that can come vicarious trauma, compassion fatigue, and other emotional side effects of the job. So it is important that we have real, authentic conversations about work and its impact on our health and well-being. So we don't expect folks to check their problems and feelings at the door. Actually, we often encourage folks to voice their concerns and needs during work. We have a sample agenda on the slide. For most meetings, we start by checking in with folks, ask your team, what do you need? How are you feeling? Then we also use icebreakers and team building activities to build peer cohesion. Next, we set aside time for individuals to share cases and problems that they're experiencing with clients. We also allow time for others to chime in and offer support to one another. Typically, we end the meeting by sharing accomplishments and highlighting wins. Informal meetings are also used, hence the picture of our group chat. And shout out to millennials and Gen Z for always keeping us updated on new tech. Informal meetings are used to address things as they come up, like recent news events. Recently with the Roe versus Wade decision, we were talking about what was going on across the country in our group chat. And These informal and informal meetings are designed and used in a manner to cultivate supportive communities and facilitate an environment of collective care. We want folks to know that your coworkers care about you and we're here for you. Next slide.
So DEI activities or diversity, equity, and inclusion activities are another tool that we use to build a community of collective care. So unfair treatment at work is considered the #1 contributor to burnout and therefore must be the #1 priority for leaders. We provide safe spaces to learn about our employees' backgrounds and confront bias and inequities. We center organizational justice by hosting movie screenings, informal and formal conversations, strategic planning activities, and book clubs. For example, we recently read Between the World and Me by Ta-Nehisi Coates, written as a letter to his teenage son, speaking on the dangers and realities that Black people face every day in a world that does not protect them. When you read and discuss books like these, people feel more comfortable in the skin they are in. They know that at their job, they can show up as they are. This then translates into the work that we do by promoting safety and support, trying to retain staff who come from marginalized communities, some of the same communities we are often trying to reach and provide sexual health services to. Work environments that are diverse and inclusive affect staff's feelings of value and sense of belonging. In collective care environments, folks know that they are important, respected, and understood. People know that others care about them and their backgrounds. So at Sac County Public Health, we are trying to focus on folks not just being an employee. We look to support all of you and how your personal attributes intersect. I can say from a personal standpoint, I'm a millennial Black woman born and raised in the Deep South. And I want to walk into a workplace that supports all of that and knows that I am an asset. Next slide, please. Another tool to sustain collective care in our workplace are outreach and engagement activities. Outreach and engagement activities can be used to promote community and connection by humanizing the workplace, building self and collective efficacy, linking humor, empathy, and cohesion, encouraging teamwork, highlighting strengths, and recognizing employee contributions. Employees are less likely to be burned out when they can connect their work to their company's mission or purpose in a way that makes their job feel important. In an environment that promotes collective care, employees feel connected to their work and they are able to see how their work connects to a larger mission. This helps create an environment where folks feel important. Some of the things that we do here: we have hosted CBO presentations. So in the past, we have had community partners present to our staff about the populations that they serve, and we want to serve better. From these presentations, our team members are able to discover how their role or daily tasks contribute to the larger work or greater purpose. We also have welcome programs, or what folks may call new employee orientations. So during our new employee orientations internally, we make it a point to highlight the purpose of our organization and show how our employees' contributions make a difference. We also host strategic planning sessions. So we involve our team in the decision making. So siloed decision making that is not transparent or does not engage employees at all levels can contribute to feelings of unfairness or disrespect. Inequitable procedures can lead to cynicism towards one's job, which can result in burnout. We've also accessed Strengths Finder before. So when people have the opportunity to tap into their strengths, they are more engaged, more effective, less stressed, and more focused on doing their best work, rather than seeing their job as a burden. So as a program, we have purchased what was previously known as Strengths Finder, but now known as Clifton Strengths by Gallup, which is an assessment that ranks a person's strengths according to their 34 themes or their 4 domains of executing, influencing, relationship building, and strategic thinking. This allows us to identify what our staff do best and praise them for it. So we also create opportunities for building solidarity and shared community, including meals and other opportunities to share work-life experiences. We host these events during work hours together. We encourage our employees to have fun and learn together to create cohesive teams with good morales. Next slide, please. So this is done through videos and pictures. And yes, we have blurred these pictures to protect the privacy of our staff. Gratitude emails, highlighting achievements, celebratory events such as baby showers and holiday parties. We establish systems for genuine, meaningful, and equitable staff appreciation to ensure staff feel motivated and rewarded in their roles. Next slide, please.
Sorry about that. That was my sound. As we close this presentation, we want to point out some resources that may be of use to folks when trying to learn more about collective care. First and foremost, there is the team. The team really will know the best way to take care of the team. So please reach out to your folks and find out what they need to feel supported. We're constantly trying to find more ways to support the folks we work with. Second, SAMHSA, which is the Substance Abuse and Mental Health Services Administration, and Gallup have published 2 really good reports on burnout and evidence-based ways on how to reduce burnout in the workplace. So please check those out. Next, there are organizations that we are just recently learning about that do a lot of work around organizational justice and employee-centered communities. There is the BIPOC Executive and the Teaching Well. The Teaching Well is more geared towards the education sector, but much of their practices are transferable to public health spaces. And finally, as you take this information in, we really want folks to think about how important it is for us to think more about what we can do to take care of each other. In our society, the focus is on individualism and taking care of yourself. We can't do this work alone. We can't end STI epidemics alone. So it's futile for us to expect folks to address their problems and issues alone, especially when they are related to work. So here is our checkout question. What is one actionable item you can take back to your organization to help with building a culture of collective care? Please drop your response in the chat if you wish. Someone put all would be ideal. Yeah, that is true. It's hard though. And Tiara and I are really big on like real, honest conversations. It's really hard to shift mindsets and cultures within an organization. And it's something we're constantly working on. But as we said earlier, we want to strive towards progress and not necessarily towards perfection. Thank you all for all the positive vibes in the chat. We love it. All righty, next slide. Please. Thank you all so much. Thank you for folks who responded in the chat. Thank you for folks for listening. And just shout out to our staff who's also on the call. If you all want to reach out to us, here is our email, our general email. And the last slide, could you go to the next slide, please? Is a list of references and resources we use to develop this presentation, and for us that we use when we're trying to learn more about collective care. And thank you all so much. Have a great day.
Thank you so much, Krystal and Tiara. We really appreciate this presentation on collective care. And as you saw in the chat, you really had everyone going. So we really and truly do appreciate that. Do you want to take 1 second to see if there was at least one question that stood out in the chat that Jerica could share before we move to our next presentation?
You guys did amazing. That was an awesome presentation. And there wasn't too many questions, but I think that just speaks to how great your presentation was. There was one asking, and you have your in your references up here, some resources that you've used, so that might be helpful for this question as well. But there was a question asking specifically if you have a list of audio book DEI resources that you could share. It's the question specifically asked about audiobooks, but I think if you had other specific DEI resources, that might help as well.
Here, I think I'm going to let you answer that because I'm pretty sure you have a list of books and stuff.
So we here we don't necessarily use audiobooks. We actually did use some of our funding to purchase just actual books for staff to be able to use, but I can create a list of those books and send them over. So we actually have the books that our staff can check out if we do a book club together, or if they want to just check them out on their own and read them. But I can always put that together for you. I'm unsure of who that was, but I can respond to you.
Can you also,
thank you so much.
There's a lot of people requesting your contact information. If you all are comfortable, would you mind sharing your contact info in the chat so folks can reach out to you individually?
Okay, we'll drop that in the chat.
Thank you.
Awesome. Thank you all again. And as we move into the next section of a presentation on reclaiming wellness using intentional plans to address and burnout with Lisa Frederick. Just a quick bio on Lisa. Lisa Frederick is a public health professional devoting over 23 years working in HIV, AIDS, viral hepatitis, Black women's health, and sexual health. She is a consultant for the Public Health Institute at Denver Health and the co-director of Black Women's Learning Institute. Lisa has experience leading technical assistance and capacity building in organizational sustainability, programmatic infrastructure, and systems development. Her expertise extends to translational educational research programs, which resulted in the development of an HIV and women's program focusing on issues of IPV, menopause, sexual health, and resilience. She has led the dissemination of Center for Disease Control's HIV Treatment Works campaign in 9 markets throughout the U.S. Lisa graduated from Empire College State University of New York with a BA in concentration in studies in social policy and research. I'll turn it over to you, Lisa. Thank you so much for joining us.
Thank you. Okay, well, let's get this started. I first wanted to thank Krystal and Tiara for that wonderful presentation, and that is what we call Black excellence, people. It was wonderful. Thank you so much for that. So again, welcome. So let's get started with reclaiming wellness using intentional plans to address stress and burnout for disease intervention workforce. But let's start by first not feeling guilty for not being in touch with our own wellness as others. So our wellness is controlled by the self and what is possible for us. So wellness is not a commodity or a program that someone can buy, but rather a journey for people to discover for themselves. Next slide, please. So just a little more introduction. My name is Lisa Frederick, and I've worked in public health, like we said, for about 23 years. I started working in HIV viral hepatitis, and for the last 10 years, I have been totally committed to doing work in Black women's health and wellness. So I'm here today, so happy to present on behalf of the mighty Denver Prevention Training Center. Founded in 1979, the Denver PTC provides innovative training, consultation, information to healthcare professionals and their organizations. The Denver PTC has the unique advantage of being a program within a public health institute. So the Public Health Institute at Denver Health that resides within a large comprehensive healthcare system, the Denver Health and Hospital Authority. So we operate in partnership with the University of Colorado, Denver School of Public Health, with whom we share an interdisciplinary staff and faculty. So our program is supported by a cooperative agreement with the U.S. Centers of Disease Control Prevention, CDC. Next slide, please. So we have 2 objectives in our session together today. So first, we want to recognize the relationship between personal well-being and thriving public health workforce. And secondly, is to describe the multiple dimensions of wellness and their relationship to stress and burnout. Next slide, please. So not that this is news to anyone in the room, but between the pandemic, increasing numbers in sexually transmitted infections, cuts in funding, and growing public health distrust, I think it's pretty fair to say that many of us are feeling tired. Many of us are stressed and burned out, and we hear that term a lot. And if you're feeling that way, we want to share some data with you to show you that you're not alone in those feelings. So the Public Health Workforce Interest and Needs Survey is called, also known as PHWINS, is the only national representative source of data about the governmental public health workforce. So it's been conducted every 3 or 4 years by the Burnout Foundation and the Association of State and Territory Health Officials, the ASTO. 2021 was the most recent survey with data and findings released in 2022. This was a big survey. The PH1 survey was distributed to 137,447 state and local government public health workers. That's representing 47 state health agencies, 29 big city health departments, 159 medium and large local health departments, and for the very first time, they included 100 small local health departments. So the survey was completed by 44,732 individuals. Now I want to show you, and let's look at some of that recent data that we got from there that really relates to what we're talking about today. Next slide, please. So the PHWIN survey included questions specifically about mental and emotional well-being. So to measure the prevalence of probable post-traumatic stress disorder, also known as PTSD, the survey included a 4-item checklist developed by the U.S. Department of Veterans Affairs. So in this screening, a person who reports having experienced 3 or more of these symptoms is considered to have probable PTSD, and more than half of public health workers, 56%, reported at least one symptom of PTSD, and 1 in 4, which was 25%, reported experienced 3 or 4 symptoms indicating probable PTSD. Now, just so we're on the same page, post-traumatic stress disorder, PTSD, is a disorder that may occur in people who have experienced or witnessed a traumatic event, series of events, or set of circumstances. Next slide, please. So among public health workforce, more than 1 in 5 employees, 22%, rated their mental health as either fair or poor. So employees working in big city health departments reported worse mental health than employees working in other types of public health departments. Now, if you're attending a day and you're thinking right now, my mental health is good, that's great, but the information we're going to share with you will apply to you. So just remember, staying proactive in our wellness is just as important as being reactive to events that might challenge our resilience. Next slide, please. So the last data that I want to share with you is related to turnover in public health, and which this is not news to anyone in the room. But a preliminary analysis of all the PHWINS participants revealed that from 2017 to 2021, the rate of employee turnover was 2 to 3 times higher than it was in 2014 to 2017. So additionally, the survey revealed that 32% of state and local employees said they were considering leaving their organization within the next year. That's a lot of people. So looking further out, nearly half of all employees, 44%, said they're planning on leaving or retiring in the next 5 years. So hearing this, that about half of all public health employees plan to leave in the next 5 years, tell me in chat how concerned this number is for you. So I want you to put a 1 in the chat if you're very concerned, put a 2 if you're somewhat concerned, and put a 3 if you're not concerned about this turnover at all. And before I finish talking, all I'm seeing is 1s coming in. We're concerned here. And your concern is just valid. I see a few threes that cannot, but I see a lot of ones coming in. So staff who indicated they were considering leaving listed their top concerns. Now, what you can see to the right side of the slide. Now, make no mistake that all of these are important factors. We look at pay and other things, important factors. But for the purpose of this, we're going to focus today's session on burnout and stress. Next slide, please. Yolanda says she's leaving as well. She's retiring. Well done, Yolanda. I hope you have a great retirement. So let's look at just wellness. So in thinking about burnout and stress, the need to focus on well-being is clearer to most people than ever before. So let's look at this definition for a moment. So wellness is an active process of becoming aware of and making choices towards a healthy and fulfilling life. It is more than being free from illness. It's a dynamic process of change and of growth. So another way I've heard wellness defined in one simple sentence was, wellness is the conscious development of the whole self. So when we look at this definition on the screen, there's an important point to highlight about this definition. First, so wellness is an active process. It's not something that happens passively. And the active process includes two key components. First, we need to become aware of how we're feeling in each dimension of our wellness, which we're going to discuss next on the next slide. But then secondly, we need to make choices to help us grow. So Eckhart Tolle, an author and a teacher, said, with awareness, there comes choice. I like that quote because what it does is sums up the work that each of us do to address our own wellness, becoming aware and then choosing. So let's explore some dimensions of wellness and talk about how to develop awareness in each of them. So let's go to the next slide, please. Okay, so today we're going to focus on the 8 dimensions used by SAMHSA, the Substance Abuse and Mental Health Service Administration. SAMHSA shares an important point here that is worth definitely pointing out. We live in a multicultural world, and wellness encompasses areas that may not be specified in this brief discussion. So the 8 dimensions of wellness are interconnected and build upon one another. So some things that you hear in one dimension might be mentioned in another. And I like this graphic with the overlapping circles because it helps to illustrate just that point. So briefly, the dimensions of wellness are physical, intellectual, environmental, emotional, financial, social, spiritual, and occupational. Now, some of these dimensions sound intuitive about what they include, but let's review in simple terms. So physical wellness is about how we are caring for our bodies. Intellectual wellness is related to how we're keeping our brains active. Environmental wellness is about how we're able to be safe and feel safe. Emotional wellness includes how we express feelings and enjoy life. Financial wellness considers how we're balancing income, debt, and savings. Social wellness looks at how we're building and maintaining relationships with others. Spiritual wellness considers how we're connecting to our personal beliefs and our personal values. And finally, occupational wellness includes how we participate in activities that provide meaning and provide us purpose. So on the next slide, we're going to bring up a QR code with the link to this resource, as well as the tools we're going to use in this presentation. So we're also going to put a hyperlink in the chat, but if you prefer to use your phone, get your phone ready. Next slide. So I hope that all goes into the chat so that, because we're going to kind of need those. So next slide, please. All righty. So thinking back to our definition of wellness, we want to start by becoming aware of our well-being satisfaction. So one way we create this awareness is by using a wellness wheel. So our wellness wheel is a visual representation of how balanced we are feeling with each wellness dimension. So there's many examples of wellness wheel, but in our example on the screen here and in the resource packet we're going to share with you in chat, we're using a 5-point satisfaction scale. So to use this wellness wheel, we invite you to look at each dimension one at a time. I want you to shade in the rings that correspond to your personal level of satisfaction. So for example, you might say that you're somewhat satisfied with your environmental wellness and shade in that portion of the circle all the way up to 4. But you might also say that you're somewhat dissatisfied with your emotional wellness. And then you would shade in that portion just to the line, just up to 2. So let's look at a complete example of a wellness wheel, and let's take it from there. Next slide, please. All right. So here is a complete example of the wellness wheel. So look at this, and you might notice that the social wellness shows high levels of satisfaction, and that the physical wellness has high levels of dissatisfaction. So scoring the charts on one dimension of wellness is great. And it shows, you know what? And I see something coming in the chat. I don't know if the link was put in there or not. I'm hoping it was, but there should have been a link actually dropped into the chat. Okay, there's a link. I think the link just came in. All right, so as I was saying, so scoring off the charts on one dimension of wellness is great, and it shows you might be thriving there. But for us to really consider our complete well-being, we want to think about ways to balance all areas of the wheel. So I really like the analogy of this flat tire and the graphic on the slide, because I think it really illustrates this point. If you think about a flat tire, you might be able to drive a short distance if there's a slow leak. But to keep moving forward without damage to the rest of the car, you're gonna have to give special attention to fixing that flat for sure. And if the tire is really flat, you might need to prioritize work on the flat before you can do anything else with that car. So that's a pretty good analogy. I hope that the links got worked out or the QR code so that everybody can participate. So using the resource packet in the chat box, I invite you to look at the blank wellness wheel, and I want you to think about your own personal satisfaction in each of these areas. So we're not going to be asking you to share your completed wheel. So really be completely honest with yourself. Think about the areas of wellness where you feel you have a lot of satisfaction, but also think about those areas where you feel you need a little more support and planning. So you might not, I'm sure I have a print and all of that, but you can use a piece of paper, a scrap paper, or even just jot down some thoughts about these dimensions if you don't, if everything didn't come, to fruition in the chat. So I'm going to give you about 2 minutes, and I want you to do some self-reflection about what we just talked about these dimensions. I'm giving about 2 minutes, do some quick little 2-minute reflections, and then we're going to come back and we're going to kind of talk some more things through. So just about 2 minutes. And I hope everyone was able to, even if so, just get a piece of paper. Okay, thank you, Christy. She just dropped the PDF handout in the chat. Teamwork. Thank you. Let me get about 2 minutes to do some reflection. All right. Okay, so I know 2 minutes is not a long time, but we had like a little time to have awareness on some overall well-being. So let's discuss how wellness plans can support each dimension of wellness. And I'm sorry this is going fast, and I really do apologize people can't open it, but if you can like even like take a screenshot of it, and you can just use like a piece of paper to kind of to do your own thing, you know, to kind of follow along here. So I hope that kind of works. So next slide, please. And Mariska said, if you click the document that Krystal shared, you need to save it on your documents, and maybe that can be a way. All right. So this is a blank wellness plan. So wellness plans include individual, self-identified activities for each dimension of our well-being. And why these activities are individual and personalized to us is because we all have different needs. We all have different preferences. We all have different capabilities, support systems, resources, and we all come from different situations. So if you came to this presentation hoping for a one-size-fits-all description of how to increase well-being in your life, I won't be able to define that for you. So these plans are about figuring out what works best for you and what is most important to you. So I'm hoping that resource packet thing got worked out, but in the resource packet that I think now put into the chat, we shared a blank template for writing a wellness plan. So the template is very basic. It includes each dimension of wellness. It includes a space to define what the dimension means to us and spaces to write down strategies at the individual, relational, and communal levels. So let's look at an example of a wellness plan. So next slide, please. All right, so this is an example of what an occupational portion of a wellness plan could include. So in this example, occupational wellness looks like feeling fulfilled in using my skills and abilities, continuing to grow professionally, and finding a good work-life balance. So strategies that I might implement at an individual level could be using my PTO, even if I just on a random Friday or Monday, give myself a 3-day weekend every once in a while. Or maybe I'm feeling, so overwhelmed with meetings, I want to start scheduling an hour or two on my calendar to not have meetings and get caught up on emails, writing reports, or other tasks that I might feel I really fall behind on. So many times when we think about our wellness, we think about individual things that we can do. So many of us probably already know individual things we can do, like going for a walk or drinking more water. But to write a comprehensive wellness plan, we also want to consider what we can do with others, either in relationships such as with our families, our friends, our co-workers, or broader activities we can do in the community. So explicitly naming strategies that we can do with others is important for a few reasons. First, the people we share these strategies with help us stay accountable to our goals and provide that love and support and encouragement that sometimes we all need. Secondly, connecting with others makes us feel less alone if we feel we're struggling in one of these dimensions. So as you write your wellness plan, I encourage you to pick more than one activity in each of these last 3 columns. Because naming multiple things doesn't mean you have to do all of them at once, but instead it gives you a menu of options to choose from. So having this menu is important because you can choose what sounds good to you each day. And it gives you a backup plan if something prevents you from using one of your usually go-to techniques. So for example, so for my emotional wellness, I recently started lifting weights with my daughter.
No, it's not. Okay, so then what are we going to eat?
I think somebody needs to mute themselves.
Ground turkey is fine.
All right. So, like I was saying,
Lisa, you just went on mute, my friend.
Did I do that myself? I just like went on mute. I didn't touch anything. All right, so I'm gonna say this one more time. So having a menu is important because you choose what sounds good to you each day. And it gives you a backup plan if something prevents you from using one of your usual go-to techniques. So again, for example, I love this. I'm so proud to say that I recently started lifting weights with my daughter for emotional wellness. So we got this cute little mother-daughter team going on, and I use it to burn off stress. So, but then, okay, I hurt my back and I couldn't do this for a few weeks. And just in that week or so, I felt that stress accumulating in my body because I didn't have another go-to technique to manage it. I missed it. I missed that working out with my daughter. I missed the close. I missed the activity. So the more proactive you can be in identifying options now, the easier it will be to implement them when challenging events happen. So of course, you know, it's going to take more time than we have together right now to complete your whole wellness plan. But I invite you to get started on the plan by picking one dimension of wellness where you might be experiencing slightly more dissatisfaction. And then either in the digital resource from the chat or on the scrap paper, and thereby start thinking about what this dimension looks like to you. So I want you to use like brief bullet points to capture your thoughts and begin to brainstorm ideas you can do individually, in relationships, or in the community. So again, we're going to take another 2 minutes here to let you get started on your activity. So use some brief bullet points to capture your thoughts and begin to brainstorm ideas of how you can individually, in relationships, or in your community, begin this. I'm giving you 2 minutes to kind of just, get your thoughts together so we can kind of start on this plan. And this plan is not going to be finished today, of course, and this is something that's going to be ongoing, but it's a great tool that we want to offer you to walk away with. It'll take about 2 minutes. And you can just write that in. Start thinking about this. So again, these plans are just for you. So we're not going to require you to share your activities that you just brainstorm, but if you're comfortable, I would invite you to take a moment to put in chat one dimension of wellness and one activity you brainstorm. So sharing your activity may inspire someone else in the session to choose something similar. So if you're comfortable, I would love to hear, one dimension of wellness and one activity you brainstorm. I see it coming in already. Robin with the yoga. Or responding to other people's anger less. Roller skating is really good. Gardening. Each early morning workouts, I love that. And weightlifting, Sonia, I'm with you, that weightlifting, and it's great for women and as we age as well. Those are some really great things. Thank you for putting those things in the chat. Learning new languages. Oh, I like karaoke. I see some good things coming up. Yes. Thank you so much. Walking is everything to me. Traveling, walking your dog. Thank you for sharing those. Cooking. Pet cuddles for sure. Okay, next slide. Thank you guys for putting that in. And I heard somebody say like loving yourself. That's really cool. Next slide, please. And I think one more, the next slide. All right, so we've already discussed the importance of picking more than one activity per column, but I have a few more best practices to share with you. So first, think of activities through a SMART framework. So SMART stands for specific, measurable, achievable, realistic, and timely. I especially want to emphasize specific and achievable activities. So for example, if I was thinking about my emotional wellness, I wanted to reduce my stress, I probably wouldn't write a broad activity like, stop getting so stressed. If it was that easy, I would have done this a long time ago. Instead, I want to pick something more realistic and achievable. like finding 5 minutes a day to focus on deep breathing exercises. So secondly, remember that wellness is a process. And because it's a process, there's no endpoint to these practices. Even if your wellness wheel has no flat spots, that self-assessment is only true for that moment in time. So tomorrow, next week, next month, or even next year, your wheel might develop a slow leak like that tire. So you ask yourself, what practice can I continue to keep my wheel full? Among these lines, remember that it's okay and encouraged to revisit your activities. The things that support your wellness right now might not be the thing that's supported in the future. Continue to check in with your wellness and think about what you need at this moment in time. And at last, remember, it's okay to feel challenged by your plans. So some studies show that it takes anywhere from 18 to 254 days to build a habit. So writing a wellness plan may not immediately increase your satisfaction with any of the dimensions of wellness, but you know what it is? It's a good start. So commit to activities you list while reminding yourself that these activities can be revisited and adjusted as needed will create measurable impact. So next slide, please. So thank you. And I do apologize for the, this is live TV. So, in the chat feature with the resource, sorry about that. But also just wanted to know if there are not really even questions, but if anyone had any comments or something really great to share with your colleagues and with us in the room, would love to have that be the last note we walk away with. So if you have anything to share, any really important words of wisdom about well-being or something like to share, please put it in chat. And thank you so much for being a part of the talk.
Thank you so much, Lisa, for sharing your expertise with us today. We really appreciate that. And as Lisa said, if you all would, please share your comments and thoughts in the chat. We would greatly appreciate it. On the screen, we also have Lisa's contact information. So if anyone wants to reach out to Lisa after today, I'm sure she wouldn't mind speaking with you one-on-one. So as we continue to move through the day, and if we could jump to the next slide. Initially, we would have been taking a break, but if it is okay with everyone, and in an effort to ensure that we end the day on time and have save room for our final round of Jeopardy, we're going to forego the break. But what we will ask for everyone, because we just coming out of self-care, would want everyone to take a moment to stand on that are coming up. The first room, breakout room A, has 4 presentations: diversity in DIS workforce, leveraging partnerships between DOH Office of Infectious Disease and IHS and Tribal Health, leadership and growth opportunities for DIS, new role, disease investigator and disease intervention specialist training coordinator. So these presentations will all take place in room A. In room B, we have impact of digital investigative approach on communicable disease investigation, utilizing motivational interview techniques to engage cases and contacts, range of approaches to address rise in congenital syphilis, and lastly, CDPH, congenital syphilis quality assurance process. All of those presentations will take place in breakout room B. If you are a presenter for any of those sessions, please take note so that you'll know which room that you need to go into. And as before, in the previous breakouts, please go into those rooms. We will be in those rooms for the remainder of the day, and we will close those at the end of the day for closeout. Sonia, who was one of the main brainchilds for today's conference, just to provide you with an official closing and next steps for the conference.
Thanks, Leo. And thank you to everyone that took the time out to join us today. What would a DIS conference be without some chaos? We are so accustomed as DIS to rolling with the punches. So I appreciate us all just really harnessing our DIS skills and rolling with the punches. We appreciate you for sticking around, coming in and out between patients and whatever else you have on your plates, which we know is unending. Thank you so much. I wanted to just note that we still have abstracts open for STD Engage. And if you don't know about STD Engage, that will be happening in New Orleans in mid-May. So stay on the lookout if you haven't seen those details through my NCSD and through the STD Weekly. And we're hoping to see all of you there and continuing this conversation. We hope this was really valuable to you, and we're going to look forward to just continuing the conversation, really amplifying our voices as DIS and for our needs in the field. And we're really looking forward to expanding our work and our professional development here. Thank you, everyone.